So a little point I missed on the undescended testicle. So sorry, go back in your notes here. I've kind of mentioned, I've alluded to the fact that an undescended testicle increases the chance of cancer. The longer it's up there, too, the more of a chance of cancer, especially the seminomas. In fact, it is 50 times more likely to become, how would that become malignant. All right, I gotta zoom up a little bit. Handwriting's horrible. So I finally figured out it's the amount of zoom that makes the handwriting legible or unlegible. What was it? It's up to 8 times more. This 50. Sometimes I really have to think about the numbers they throw at me. 50 times more likely to become malignant, but then 8 times more for seminoma. And I just said that the seminoma was 8 times more for seminoma. I'm going to throw out all my notes here. 8 times question mark. All right. Yeah, just a little something I'll double check on that because that didn't suddenly, you know, now that I'm saying it out loud, it's like, well, that doesn't make a lot of sense. In any case, undescended testicles, very important to know about because of very, very high increased risk of cancer, regardless of the 8 times, 50 times. It's definitely a very high. Even in the contralateral, contralateral testicle increase malignancy rate. I'll put a question mark, an exclamation point. That's kind of weird. I wouldn't understand the biochemical effects of that unless it's just. Actually, I don't know. I don't get it. I don't see how if the right testicle is undescended for some period of time, how that would affect the left. But apparently, it does. Undescended testicles, you could have actually intra-abdominal. So if it's all the way up in the abdomen, if it's in the canal, it's not going to twist. It's very unlikely to twist because it is tight stuffed in there, as you can see in these images above. But if it's all the way up in the abdomen, then it is free to spin around. So increased torsion if in the abdomen. And let's see, and and what's left over is usually a patent. You know, that means open when it shouldn't be open. Well, in this case, when it shouldn't be open, a patent vaginalis or patent inguinal canal. You know, we call it, you know, like the process vaginalis, we call it the inguinal canal. It's out in the field, we just say inguinal canal. The doctor says, "Did you look at the inguinal canal?" "Yes, doctor, I did." So inguinal canal is the space, really the physical space that everything else is inside of as it comes out of the abdomen and into the scrotum. Okay, so that was one thing I missed. Not a big deal. There are those pictures again of the inguinal. Look at this. You don't know for sure just by looking at this, but this certainly appears like a small, flattened out testicle. This is well. This is just under the. Let's see. That's peritoneum here, and then, you know, just a little bit of fat under the skin. So this might be all the way back in the abdomen, this one. These two, and that one too. These two in the middle, and let's see. And the first four are definitely inguinal canal. You can kind of see this is, I don't know how to explain it. It's just, you can tell that's all canal there, especially these two. You can tell it's all canal. Okay. So one of the things I talked about last time was the protocol. It's really quick. In fact, I'm just going to do it on these guys right here. I just drew these out right before class. And I'm just going to draw lines. Lines are hopefully going to, there's going to be a lot of lines. So just kind of pay attention. You don't have to follow along in your notes. It'll be too confusing. The first image, yeah, let's just do lines. Actually, I'll make my line bigger. Okay. You know, the first two images, transducers laid right across the middle, both testicles. We're looking for any obvious differences between testicle echogenicity, size, and then blood flow. Really important for that blood flow. And that's why I start here. And that's why most people start here and not messing around up in the inguinal canal like the book says. Because one of the first things the doctor wants to know is there blood flow to both sides, or is there increased blood flow? So as when you compare the two, this looks like a anyway. As you're comparing the two, they might both have blood flow, but one of them might be increased by a considerable amount. So that's epididymitis. Orchitis, or perhaps you catch epididymitis at the same time. So first two images right there. Then my images, I go to the right side and I just work my way down. And then on the right side, let's see, I'm going to take sagittal images. Of course, my sagittals are going to look like this, at least in midline. And of course, I already missed telling you something about measurements, and so I'm going to measure length of the testicle. I can measure height or AP either here or in trans. I don't really care. And then if I measure those two, and then I can come over here. Let's just give me another. Let's give me another. Whoa, that's an ugly looking testicle. All right. And then, oh no, I'm sorry, because transverse, it's not going to be like that quite, right? On your scan, on your image, it's going to be round and transverse. At least we hope so. And then we take another measurement across here. And I like to do these either split screen or within one image of each other. Just makes it nice, not only for the doctor, but also for you. If you don't have this recorded in a worksheet automatically, and a lot of machines won't do that for you, or they're not set up, then it's nice for you to be able to go back and within two images, find all of your measurements for the testicle. And then we do the same thing, on a smaller scale here. We'll measure the head there, and then I usually do some kind of other measurement there. And then in transverse head, off the top of this testicle, you're going to find, I'm just going to put it all the way over here though. It might look like that. It might be a little, well, of course that happened anyway. Then we measure across there. So we have 3 measurements of the head, 3 measurements of the testicle. Then we look up in the inguinal canal. Let's just give us a little room here. I usually start sagittal. It doesn't really matter. A sagittal image here, maybe another one a little higher up. Valsalva. And then if I want to, I could take my transducer transverse and even just slide it all the way down. just slide it down. And when you do that, the nice thing about that is you kind of get to see, it's almost like you create a movie of the inguinal canal and the spermatic cord. And if there's any kind of twisting in the spermatic cord as you're coming down, you'll see it twist as you're coming down. Okay, quick, and Doppler, Doppler, Doppler all the time with that. Okay, that was a real quick review of that. And what else did we talk about? We'll just kind of, oh, you know what, let's, the bell clapper. Of course, so what I drew here, I thought about, I was laying in bed last night thinking, did they understand what my bell was? This is a hand bell. I don't know if you've ever, ding-a-ling-a-ding, you know, the British are coming or whatever. That's the handle of the bell, and this is the metal part, and obviously that's the clapper, the bell clapper. And so with the bell clapper deformity, what this represents then is the spermatic cord, the testicle itself, and the scrotum, or at least the space inside of the scrotum. And normally men should not have the ability to clap around like that. It should be more a space on one side of the testicle, not on both sides. And that's, I kind of drew that over here. And what I'm filling in right now, that's the space, that's the normal space. We have a bare area kind of holding the testicle down. But then if the bell clapper deformity, it's just simply the space, the parietal and visceral layer, or really the space between the parietal and visceral layer goes too far around the testicle, allowing it to twist far more easily. Extremely painful. There's not a lot of emergencies in ultrasound. I mean, absolute, you got to get there like in the next 5 minutes emergencies. This is one. Suspected torsion in the female is a hell of a lot harder to guess on because there's so many other things that cause intense pain. But if you suspect torsion in the female as well, that's another one. Ectopic pregnancies. I had a woman go downhill so fast, it was terrifying. And I knew it. I went to go get her in the ER, and I just took one look at her. I said, something's not feeling right. And so I went and grabbed my machine and brought it to her. And sure enough, she went into shock while I was in the room with her. I ran out, and they took her straight to the surgery. And she did have an ectopic, of course. What are the others? I guess a fast emergency, where a fast exam where you're looking for internal bleeding. But most locations, that is so, it's needed so fast and so on the spot, and with all these people running around, the doctor usually does it, the ER doctor does it themselves with their own portable ultrasound. What other like absolute emergencies? There's other urgent exams, but emergencies like the patient is either going to die or lose a part, that's about it. I mean, like a appendicitis is urgent, but usually not a absolute abject emergency. Get there within the next 2 minutes or you'll die or something. Okay, anyway, so we talked about that. There could be a whirlpool sign in the inguinal canal. This whirlpool sign would be, and that would be the actual twisting of the stalk, torsion of the spermatic cord, excuse me. And we talked about rupture, and of course you're going to know it's a rupture because that's what their patient history is. You don't spontaneously rupture, at least I really hope not. So if they have a history of a stratal injury, that's what you're looking for, is any evidence of a rupture or a hematoma. Probably the #1 reason for pain is epididymitis, orchitis, or epididymoorchitis. It almost pretty much always going to start in the epididymis, start in the tail, because it's bacteria traveling backwards down the vas deferens. And of course, it's going to reach the tail first, then the body, then the head, then the testicle. Although in my experience, it seems like the head is the most common place, but that's just because that's where I've always seen the most hyperemia during epididymitis. And so that epididymitis orchitis can be anything from chlamydia to gonorrhea to, if you're less sexually active, E. coli to Proteus. And the case of me and my stint with karate, post-traumatic. That hurt me for a decade. Finally went away. That was really fun. Hydroceles, we find these all the time. You know, on this image over here, we got a triple whammy. We got a hydrocele over here. We have a spermatocele over here. It's actually a transverse picture, or somewhat transverse. This testicle is a little bit deformed from all the different pressures on it, from the cyst to the hydrocele to the transducer pressure to the ligament, the remnant gubernaculum hanging off. Oh, that's the gubernaculum. No, it's got to be sagittal. And spermatoceles you find, yeah, it's got to be sagittal. It's not really shaped correctly. And then I'm also looking at the reedy testis here, and it looks like a transverse view of the reedy testis, but this has got to be a sagittal image, because you find spermatoceles almost always at the head, which is superior, and the gubernaculum at the inferior end. So then I drew in a little scrotal mouse here. Those are common, little calcification, kind of rolling around in there. Mouse or pearl or scrotal lith. And then I postulated that this person not only has a hydrocele, but a bell clapper anomaly, or let's see, this looks, you know, there's something just weird about this. It's almost, I wonder if this is post-traumatic question. It almost looks post-traumatic. And if that's the case, the testicle can be essentially torn away from the attachment point. I've seen that before. Oh, and I've also seen the epididymis basically separated from the testicle, and whether that was a previous injury or not, I'm not sure. There's a little pearl there. Let's see, let's come back. And then we went to, I told you my story about the princess and the pea. I was the princess. Like I said, spermatoceles are usually up here by there's the head of the epididymis, pretty much isoechoic with the testicle. I kind of drew in some spots in here, because if that's a spermatocele, sometimes, not all the times, but sometimes you will see floating debris inside of there. Whereas an epididymal cyst, this could be an epididymal cyst too. Certainly, since I drew in the floaters there, but an epididymal cyst can be down here, it can be here, it can be here, it can be all the way down the tail. So these are anywhere along the epi, whereas the spermatoceles tend to be at the head. Tubular ectasia, we talked about that. We've kind of talked about this a number of times, and this is a real mild case here. And nothing wrong with this. Oftentimes post-vasectomy, oftentimes an obstruction, which a vasectomy would cause an obstruction. A cyst up in the head of the pancreas, head of the epididymis will cause this, and inflammation as well. Those are common. Varicocele, or the bag of worms. And when we start seeing large veins, almost always on the left, and you put Doppler on that, and you have Valsalva, and it lights up like crazy. It's really fun. And of course, these could be incompetent valves. Nutcracker syndrome can cause infertility. 98% on the left side. And then let's say ectatic veins could go all the way to the reedy testis, which makes perfect sense, but I've never seen that before. So I don't know how common that is. Hernias, they could be a hernia of where the muscles were just weak and intestines have pushed into the inguinal canal, but not all the way down into the scrotum. And then whereas an indirect, which is more common in children, but not unheard of in men, in older men, where the intestines, the omentum, the fat, the intestines, and certainly almost guaranteed some fluid will go into the scrotum. If it's reducible, that means it goes back. It's just weird doctor talk. Like this, they use the same term when they put a bone back together. They reduce the break. I don't know. It's just weird. That's a weird way they talk. But if it's reducible, it goes back in. If it's non-reducible, then it does not go back in. And if it's strangulated, that specifically is non-reducible and the blood supply is cut off. It's been strangled. So more trauma, if you're going to have a hematoma, you probably have some kind of straddle injury. Hematoma could be in the scrotum, it could be in the testicle, but really when we're talking about hematocele, now you're talking about in the blood in that space. So in other words, it's just like a hydrocele, except it's blood. And piloceles, we just went through that real fast. I don't have an image specifically of a pilocele because quite frankly, they look they look very similar to hematoceles. Okay, I know that was really fast, but like it is review, and we do have this on video. I thought it was. Okay, I must have asked it a while ago. Okay, so really starting today with granulomatosis. That is tuberculosis, granulomatosis. It's usually going to be seen in the epididymis, I'll say first, and then secondary, you can be seen in the testicle as well. In the case of like the epididymis, like this looks like focal epididymitis on the tail of the epididymis. Except the difference is it's not hyperemic. So if I see this and I think, oh wow, look at that bad epididymitis, and then I put color on it and there's really no flow in it, that's more likely to be TB. Of course, generally we're going to know patient history, and we're going to know that the patient has either had or currently has tuberculosis. If you don't know the history of TB, the chances of you knowing that it's a TB granuloma is very small. Actually, there's one I didn't, there was in that same paragraph, um, sarcoidosis is another granuloma forming condition, and that is idiopathic. Sarcoidosis is an idiopathic disease state where you have granulomas all over the body. So you're going to find them in the spleen as well, but it could be there. So sarcoidosis can also cause varying degrees of granulomas. Okay, let me slow down here. I'm going a little fast. Tunica albuginea cysts. These are idiopathic as well. They're idiopathic. They don't really know where they come from. Just realized I didn't know where in the right spot of my notes. All these. So these guys, these tend to be small. They're always benign. They're never really a worry, but they can be palpated. Whereas if you have a cyst in the testicle, let's say it's that size, whatever size that is, you're never going to know it. You're never going to know it until you get an ultrasound. But this one, as you run your finger over the scrotum, you're going to feel a little boop, little bump right there. And of course, the guy is going to freak out. He's going to run to his doctor. And they're going to order an ultrasound, and you're going to find a tunica albuginea cyst. They are small, like 2 to 5 millimeters small. They're simple cysts, and they always involve the tunica. So here, wow, this is actually, think about how this, okay, yeah. We have skin layer here, scrotum, there. And you can see if the transducer wasn't pushing down, that would actually bump out. On another level, the tunica albuginea is just going right around here, and then bam, interrupted. So any cyst that is either crossing or right underneath and small like that, that's a tunica albuginea cyst. Don't know where they come from. They do know that they are completely harmless. Simple cyst. Well, those occur. Your book says 10% over 40. Well, that's pretty impressive, because I've done hundreds of these exams, and I don't know that I've ever seen anything that looks like this in the middle of the testicle. So either I'm really bad and I missed them all, or it's not 10%. Anyway, let's see. They could be caused by obstruction, question mark. This guy seems to be out on his own. A lot of times when you do find them, they're a little closer to the reedy testis. So, maybe this location would have been a little more common. So the same reason you would have ductal ataxia is the same reason you might have a simple cyst, just simply an obstruction. Oh, what else did I write about this? And then question previous trauma, question previous infection. But once again, totally and utterly benign. So like many other cysts in the body, we just take a look at them, measure them, of course, and then keep moving on. Another granuloma that you can find is the sperm granuloma, otherwise known as spermy grannies. They're caused by, let's see, extravasation. Did I spell that right? Yes. Of spermatozoa. Got that one too. Extravasation. That just means somehow they got out. Who let the sperm out? Anyway, when they get out like that, they could they could cause an inflammatory reaction. Granulomas are always inflammatory reactions, and so there's one right there. The problem is when you're doing this exam, there's no way you're going to know what that is, but it could be a granuloma. It could be a leiomyoma. It could be a lipoma. All sorts of things. And these do tend to be solid. All right, yeah, down to the bottom of that. Okay. Now I'm going to try not to bore the daylights out of all of you, but we've just got a bunch of things we got to go through here. Extratesticular, almost always benign, but almost. I mean, obviously there's always a chance, very small chance of cancer outside. So in other words, if it is in the scrotum, I guess inguinal canal or scrotum, and you find a mass, it is vast majority are benign. And the number one to find is adenomatoid tumor. Tumor. Adenoid tumor, usually in the epithelial, but can occur anywhere. So usually epithelial. Just right. Okay. Usually epithelial, but it can be anywhere. Like in this one, this is supposedly a very small little adenoid tumor. But boy, look at the distortion it creates on that testicle, which is, you know, when you own them, ladies, you don't really expect them to bend that much. But I guess if it's sitting there for a long enough period of time, it just kind of grows like that. And these are circumscribed. Whoops. Circumscribed. In other words, you can clearly see the edge, and the technologist was clearly able to measure that in length and height there without a problem. And this is probably, I mean, this looks like a sagittal image. We just got, by the way, on this side of the image, that's just a loss of contact. So and by the way, you got to use a lot of gel. You use more gel per surface area on one of these exams than you would somewhere else, simply because of the nature of a scrotum. And if there's hair, then you have to get enough gel around each hair follicle so that there's no air bubbles. But anyways, they have a loss of contact at this end, so there's nothing going on over here. And this is probably a sagittal image. Region of interest, probably a sagittal image, and then it says transverse right there. Thank you very much. That's transverse. What do I know? Anyway, circumscribed, solid variable echogicity, indistinguished from other tumors. So typically, solid and variable echogenicity, variable echogenicity, and virtually indistinguishable from other tumors. Once again, you're not going to know what it is just by looking at it. You have to stick a needle in it. Next thing, now if you see this picture, oh my God, this is the most beautiful image, because a leiomyoma is the same exact tumor that women get. Now, leiomyomas can happen in a number of locations in the body. They can happen in the GI tract, but we normally think of them as fibroids, uterine fibroids. But they are a soft tissue, or I'm sorry, a soft tissue, a smooth muscle tumor. And so, and they are benign. And what else do I write about? And in the case of extra-testicular masses, these come from the epididymis. You're like, wait a minute, smooth muscle, epididymis? Isn't epididymis just a tube? Well, yes, but there's muscles in there that help propel the sperm along. So there's smooth muscles in there, tiny, tiny, tiny little muscles. Well, if there's smooth muscles, you can get a leiomyoma. And this one's really cool because a lot of times, if you look at a uterine fibroid, you can see there's kind of a swirling pattern in uterine fibroids. Not always, sometimes they're really rough, but this one you can definitely see a swirling pattern. And that's just basically all smooth muscle overgrowth. Another benign one is a lipoma. And look at this guy. This guy is incredible. 1, 2, 3. 1, 2, 3. What do I say? Fat more likely to involve spermatocoel. Lipomas are just overgrowths of fat. We see them in all parts of the body. I actually thought, when I was looking at this picture, I thought for sure that one, draw a straight line if I don't have it straight. I thought for sure that one was the lipoma. The reason I thought that is because this one, that's definitely not. But it had, look at this it almost looks like it has through transmission. And I don't know, well, testicles don't have through transmission, do they? But if you look really closely, this one's got like, look at that outside layer around that. That is an indicator of a tunica albuginea. Whereas this one, it's almost hypoechoic here, whereas the tunica albuginea is usually slightly echogenic. We were barely seeing anything, but yeah. So according to the article, this one was the lipoma, but that must have been a little freaky to see. And I've actually seen something very similar to this, where it's like, oh my God, the guy has three nuts. But he didn't, and neither did that patient. Benign intratesticular neoplasms. So, let me go. All right. These guys are so similar that some books combine into one tumor. and then other books don't. They kind of call them separately. And so, and I've looked it up. I've kind of seen both. So I think there's such a similarity between the Leydig and Sertoli tumors that pretty much I have just the same thing to say about. Let's see. Well, except so I see them a lot as Leydig Sertoli, which confuses me because then the book has them a little bit separate. But if we do separate them, a Leydig tumor, well, they're both rare. So I'm just going to put rare here for both of them. 90% benign, which means that 10% of them are not benign. So they can be cancerous. And I just wrote, I didn't have a lot of room, so I put F/U hormones, which I think means the hormones are a little bit out of whack. Hormones, I'm not going to put F up. Hormones issues. So a lot of times the person comes to ultrasound or goes to their doctor because of hormonal issues. And that's when we find the tumor after that. The Sertoli, if you're going to separate that one out a little bit more, that one can cause, that is rare as well, it can cause feminization. Well, if you really think about it, hormone issues and feminization are the same thing. So these really are the same. It can cause feminization or be caused, let's see, or, now let's see, I want to get this right. Associated, this is not in your book. I had to do a little research because I wasn't satisfied. Or associated with other things, other genetic things that cause feminization, like Klinefelter syndrome. Those are XXY individuals. So they are male, but they have some issues of micropenis, small testicles. They might not even know they have Klinefelter syndrome until later in life, because it's not that big of a deal, although that's a big deal. But anyways, a couple of images. Once again, you will not know from imaging alone that that is a Leydig tumor and that's a Sertoli tumor. Interesting, this one's causing shadowing here. So those are those. Another one we could find, which is benign, is an epidermoid cyst. And if you're really lucky to find one of these, most common benign intratesticular neoplasm. Remember, the most common intratesticular neoplasm, period, is cancer. But look at that, isn't that pretty? That is so cool. So it's like if you see an onion or a really tight swirling pattern like that, it's an epidermoid. What else? I probably wrote nothing for it. Target sign. Yeah, nothing else. Just that it is what it is. You might find that, you might not. Microlithiasis. Okay, we'll talk a little bit more about this. So this is a fairly minor case of microlithiasis. I saw one where the radiologist couldn't believe it. He was jumping up and down practically. He was so excited to see it. I'm like, well, that's nice, but poor patients are going to suffer. But the microlithiasis is strongly associated with cancer. So greatly increased chance of future or concurrent, there might be cancer already hidden in there, but we'll just say future cancer. And so with these people, a lot of times doctors will say, look, we want to see you once a year. Come back to ultrasound once a year. We're going to take a look at you once a year until a certain age to make sure that cancer does not form. But let's see, I have some other lines in there. What were those? It's associated with infertility. Associated with infertility. Associated with infertility. Associated with Down syndrome. Down's syndrome, and that's trisomy 21. And also Klinefelter's syndrome. But the big thing with microlithiasis, and if you see, what was it? It was in any field of view, not over the entire testicle, but in any field of view, if you see more than 4 or 5, it's microlithiasis. So in this field of view, we see probably 30, 40 microlithiasis. So definitely a case of microlithiasis, although I've seen it much worse. But even if there was only one, I can't see that. 1, 2, 3, 4, 5. Oh, it's like the 6. Here we got the Little Dipper going. Even if it was that many, it would be considered microlithiasis. But if it's only, let's just play it safe and say 2, then it's not microlithiasis, and there's no increase in cancer risk. It has to be a number. So these I just lumped all together pretty much, and we'll go through them. These are all rare. Extratesticular and malignant. I've already told you that almost all the time, intratesticular, cancer, extratesticular, not cancer. But obviously there's exceptions to those rules. And these are all sarcomas, except for the last one is a mesenchyma, but sarcomas, those are generally cancers of connective tissue. Rhabdosarcoma, I have this one separated because this is the only one that is predominantly seen in pediatric. And then the others, leiomyosarcoma, lipomyosarcoma, fibromyosarcoma. So obviously, muscle, fat, fibrotic tissue. And then mesenchyma, mesenchyme is more of a base tissue. So, but all of these are more adult men. Actually, adult and I want to say, didn't write it down, but I want to say plus 40, 40 plus years old, typically where you see these. And these are actually, so here's a rhabdomyosarcoma. This testicle is being squeezed out sideways while a large mass is growing next to it. And the others are going to have similar appearances. So I didn't bother grabbing other images for that. Let's see, 52. Let's see. Let me get through this, guys. We'll give you a break. Then we come back. I want to go. I have a video. Seminoma. So the NOS is the #1 intratesticular mass, intratesticular cancerous mass, which is mass in general. It is a seminoma. Let's see, where do I want to try? I think right here, 40 to 50-year-old men are more likely to get the seminoma. It is a germ cell tumor. Well, that just simply pretty much just means it's either a testicle or a ovary. So it's a germ cells are found in the gonads. Germ cell tumor, much increased incidence with undescended testicles, increase incidence with microlithiasis. So that's why we worry about microlithiasis, and those men now have to come back for yearly checkups. They tend to be circumscribed, so they're not. They don't tend to look really aggressive and go right through the tunica albuginea with extensions and everything. Hypoechoic and hyperemic. And so we got a little picture right here of a seminoma. But as we'll see in a little bit, this actually could, gosh, this could be a lymphoma as well. So seminoma, #1. #2, embryonal. No, it's embryonal, I believe. Cell carcinoma, #2. Go away. And let's see, this is 25 to 35-year-olds. I wonder if that's what the Tour de France, God, I can't think of his name. You know what I'm talking about. I wonder if that's what he had, because it tends to hit younger men. Oh, you know what? I don't, well, anyway. This has the most aggressive growth of the cancers, although it's not the most deadly. It could be infiltrating, although I gotta say this one doesn't really look, well, you know what, if you look at this, it kind of is infiltrating. It looks actually pretty well circumscribed. And it's even got a hypoechoic halo, which tells you that it's growing pretty quickly, but it is kind of, it does kind of have a little bit of a funny growth pattern here. And then it goes, it's more circular down here. So maybe a little bit infiltrating on that one, but infiltrating. And then what was the last thing I wrote about this? Oh, and this is really weird. This is so funny. You know, AFP. And human so alpha fetal protein and human chorionic gonadotropin are increased. If this guy took a pregnancy test, he would be pregnant, which is kind of funny. A lot of the same hormones that are found in pregnancy are actually found in men as well. We're not that different. So if one of the ways that they know is by looking at, obviously at the image and then at the blood work, and then they truly, and probably with this, they won't even take their time on sticking a needle in it. They might just suggest removing the testicle immediately. So how do you go to your, you go to the doctor and just sort of find out that's going to happen. Choriocarcinoma, that's rare. I mean, more rare than the others. This one is also 20 to 30-year-old. And this is the most, this one's the most deadly. And I believe the book said most men are dead within a year of them finding choriocarcinoma. It could be solid and cystic. Cystic areas are probably necrosis. And this one has increased HCG as well, human chorionic gonadotropin. One would expect it. It's called choriocarcinoma, so chorionic gonadotropin is increased. That's something we normally think of is women when they are pregnant, their HCG levels are high. Teratomas, those are the fun ones. These are the ones where, like, oh my God, they took a tumor out and they found out it was my twin. It was my I had an identical twin. No, that's not. That does happen, but it's so incredibly rare that that's probably not what happened to you. The dingbats telling you that. But the teratoma does have all layers of human tissue, and so I don't know so much about a testicle teratoma, maybe not, but a lot of times a teratoma can have like a little row of teeth in it. It could actually have an eyeball looking at you as you open it up. There's like a little eyeball going, "Help me." Oftentimes there's hair and there's fat, little pieces of bone, because it is basically all three germ cell layers of tissue, and teratomas do tend to grow in ovaries and testicles more than anything because they have the germ cells. They have those almost like stem cells, like a embryologic type cell where these form. In any case, teratomas most commonly seen in pediatrics. So pediatric tumor, most likely. All cell layers, mesoderm, ectoderm, endoderm. They could be large, and they're always, oftentimes very heterogeneous because you're dealing with bone and fat and hair and whatever else is in there. And they don't tend to be invasive, so they tend to be more circumscribed. When you see really heavy shadowing like that in a tumor, it's an indication, obviously, of some serious calcification. And in the case of a testicle, that is probably going to be a teratoma. And then a yolk sac tumor. It's kind of a weird name for tumor found in the testicle. These are young pediatrics, so usually less than 2 years old. Most common testicular tumor of pediatrics. So most common ped testicle tumor, and of course this baby's going to have an increased alpha fetal protein. Gosh, there was one I didn't involve here. So just metastases can occur in the testicle, although obviously other organs are more likely to get metastases. Lymphoma and leukemia. a lymph cancer, white blood cell cancer, but they are, oh, my internet connection is unstable. But their appearance is so similar that both of them will simply create an enlarged hypoechoic and hyperemic testicles. So the entire testicle is enlarged because these are really super infiltrating. They can create specific little areas, but when it comes to the testicle, they tend to take up the entire testicle or almost the entire testicle. So really infiltrating, therefore, when they increase in size, the whole testicle simply increases in size rather than like a tumor within the testicle increasing. Let me just write one thing down. I didn't put it here before, but mixed. A lot of the germ cell tumors, it's actually fairly rare for them to be pure, like purely a teratoma or purely an embryonal cell. There's usually some other kind of cancer mixed in with them, and so with mixed, the most common mixed is the carcinoma, and that is a mixture of a teratoma plus embryonal cell. And these just tend to be aggressive and dangerous. That was it for that. Okay. I got you all the way to 205. You're probably hating me right now. Let's see what else. All that, guys. So let me before I forget, there's just a couple of things. Next week we start lab. I could wear jeans. You can't. Sorry. I asked, and they said no. You guys have to wear your scrubs. So scrubs next week. I had to change the schedule, so I'm going to send a new schedule out. I'll just go ahead and send it to everyone. Most of you unchanged, just a couple of you have changed. Next chapter starts tomorrow. And that chapter is musculoskeletal, MSK. I am not an expert in MSK. I have never even met an expert in MSK. I've never worked with one. It's a fairly new. In fact, I was planning on going before the pandemic. I was planning on going to a seminar and get a crash course in it. But I'm not going to go over the entire chapter. First of all, MSK is actually a brand new requirement for ultrasound schools. And second of all, it's not worth my time or your time for me to struggle through an entire shoulder when I've never even done one myself and really don't know enough about it. But I do know enough about MSK to know the difference between what things look like in general, because I have done some MSK. I'm pretty much all self-taught. So in any case, we'll talk a little bit about the basic views of what we look at with MSK, what we're basically looking for, and then we'll probably, I'll pull up a good video and we'll just do that. So tomorrow should be a fairly easy day. And then we get into pediatric abdomen. That's a gigantic chapter as well. Pediatrics is a specialty, but we're going to concentrate on what the major differences, not the entire exam, which is really the same thing as what we've already learned, but some of the major differences between, you know, adults and pediatrics. So we'll do that, and then after that, oh gosh, we have spine, brain, all sorts of pediatric stuff. So we'll get into that as well. Of course, that's going to be pre-recorded. But okay, take a break. Let's just call it 2:10. Let's give you let's make it 2:20. And then when we come back, we're going to be just watching a video. So just kind of kick back and relax. All right. Well, I'll be stopping in occasionally, but this is pretty good.
Superficial location.
So we'll see.
We use high-frequency probes of 7.5 to 15 megahertz frequency, and these probes are typically linear or curvilinear transducers. This is a transverse view of the scrotum showing the right testicle adjacent to the left testicle. It's important when evaluating the scrotum to take an image showing the two testicles side by side for comparison of echogenicity and size. And then to take a longitudinal view of the testicle as well. And this is a longitudinal view of one of the testicles showing homogeneous echo texture throughout the testicular parenchyma. We also look for the epididymis when we evaluate the testicles and the scrotum. The epididymal head sits at the superior aspect of the testicle, and its echogenicity is similar to the testicular parenchyma itself. Now, the blood flow to the testicle comes via the testicular artery, and that artery provides a branch to the capsule of the testicle, which travels around the periphery of the testicle and gives branches into the parenchyma of the testicle that are called centripetal branches. So here's a diagram showing that the testicular artery extends to the scrotum, and then when it comes into the scrotum, it branches into that capsular artery that travels at the periphery of the testicle and gives off those centripetal branches to provide blood flow into the testicular parenchyma. With Doppler, we can evaluate the blood flow to the testicle, and typically we will see the capsular artery more easily than the centripetal artery, so we'll see flow at the periphery of the testicle. We may see scattered flow within the testicle itself, which are portions of the centripetal arteries. Typically, we see minimal flow inside the epididymis, less than what's seen inside the testicle. So here we have a transverse view of the scrotum. We can see both testicles, and we see blood flow scattered throughout the testicular parenchyma. And on this longitudinal view, we can see up in this corner the capsular artery, as well as blood flow inside and scattered throughout the testicular parenchyma. One of the most important reasons we do ultrasound of the scrotum is to look for testicular or other scrotal neoplasms. It's important to immediately determine whether a mass in the scrotum is intratesticular, because those masses are typically malignant, or extratesticular, which are usually benign lesions. Testicular tumors are mostly malignant. The most common kind are germ cell tumors. About 95% of them will prove to have germ cell origin, being either seminomas, embryonal cell cancers, teratocarcinomas, choriocarcinomas, or a mixed germ cell tumor. We also may find other malignancies inside the testicle, including Sertoli cell or Leydig cell cancers, or metastatic disease. So here's a patient who has a right testicular mass. You can see this lobular mass lesion in the posterior aspect of the right testicle. On this longitudinal view, we can see it's in the mid portion as well as the lower pole of the testicle, and this mass proved to be a seminoma. This patient has a more heterogeneous mass. It has some cystic areas, some hypoechoic areas, and some brighter areas. It also has a lot of blood flow, and this proved to be a mixed germ cell tumor. When evaluating for a testicular tumor, it's important not to let the patient's history deter you from making the diagnosis of tumor. That is, many patients present with symptoms and yet actually have a tumor. 15% of patients who actually have testicular cancer come in with symptoms of epididymitis, and 10% have a history of trauma. So a quarter of patients with testicular tumor will be evaluated for symptoms unrelated to their tumor. So don't let the patient's history prevent you from making the diagnosis of a tumor. This patient came into the emergency room after trauma. His scrotum was scanned, and we can see normal parenchyma in the lower pole, but a hypoechoic area with calcification in the upper pole. It was questioned as to whether this was a hematoma, but it's not a hematoma, it's a teratocarcinoma. Now, testicular tumors typically have increased vascularity compared to the surrounding testicular parenchyma, and the flow in the vessels is usually low resistant. Unfortunately, benign tumors also have increased vascularity, so we can't use color Doppler to distinguish benign from malignant tumors. So here, for example, is a seminoma. You can see a hypoechoic mass in the testicle surrounded by normal testicular parenchyma, and you can see that the blood flow inside the mass is greater than the blood flow in the surrounding parenchyma, so it's hypervascular. In addition, when we put the Doppler gate over an artery that's traveling through that tumor, we see that based on the waveform, this is low resistance flow, typical of a testicular tumor. But here's a Leydig cell tumor. We see a well-defined hypoechoic mass in the testicle with surrounding parenchyma. Note how hypervascular this lesion is as well. So while this one was benign and the prior was malignant, both tumors had increased vascularity. We occasionally encounter metastases inside the testicle. These do look again like tumors because they're focal lesions. We may see leukemia or lymphoma. Sometimes genitourinary primaries will metastasize to the testicle, and rarely other primaries may be seen there as well. On ultrasound, we'll see a focal mass in most cases, but occasionally some of these metastatic lesions will be diffuse infiltration, particularly lymphoma or leukemia. So this patient has leukemia, and the left testicle was enlarged and filled with this hypoechoic region in the mid and lower pole. This represented leukemic infiltration of that part. Notice that the left testicle on transverse view appears larger than the right testicle, and also notice that the involved portion, the leukemic portion, is hypervascular compared to the normal right side. This patient has a gastrointestinal stromal tumor with a metastasis to the scrotum. You can see in the side of this testicle a well-defined mass here, and here it is on the still image. About 5% of intratesticular tumors are benign lesions. When they are benign, they're typically dermoids or epidermoids or Leydig cell tumors. Here we can see a Sertoli Leydig cell tumor that was benign but has the same appearance as some of our testicular cancers. It's a well-defined lesion in the lower pole of the testicle. It does have some cystic areas, but mostly it's solid. On transverse view, we can see it has a lobular contour with a few cystic areas, and we can see how heterogeneous the mass is compared to the normal parenchyma of the left side and of the upper pole on the right side. This patient has a dermoid tumor. Fortunately, we were able to determine that this was a dermoid tumor prior to the surgery. Here you can see the testicular parenchyma is adjacent to this large mass. The mass is here and has an echogenic region with shadowing in the posterior aspect. This is sometimes called the plug syndrome due to a clump of fat or calcium inside.
I'm sorry, guys. Dermoid tumors are the same thing as teratomas.
The dermoid tumor. This was surgically excised, and you can see the hair that may be typically seen inside this, as well as that clump of shadowing which represented a mass protruding into this dermoid tumor. An epidermoid tumor also may sometimes have a characteristic appearance, allowing us to make a diagnosis that the lesion is benign. Here you can see the typical swirling or onion skin pattern of this tumor. Well-defined lesion inside the testicle. The swirling pattern is typical for a benign epidermoid tumor. Now, besides looking at masses inside the testicle, we look at the testicle for other reasons, including to evaluate the testicular parenchyma. And one thing we might see is microlithiasis. Microlithiasis are tiny little calcifications scattered throughout the testicular parenchyma. The prevalence is about 9% with the current ultrasound technology that we have, and this prevalence has increased since a decade ago because our ultrasound transducers have improved. The risk of malignant tumors in patients with microlithiasis is 8 times higher than those without microlithiasis. And typically, the tumors are more often germ cell tumors and more often pure seminomas than are tumors in patients without microlithiasis. And these numbers are based on a study we did of over 6,000 patients at Brigham and Women's Hospital. So here's a patient with bilateral microlithiasis. You can see on the transverse view that both testicles are filled with these tiny little bright echoes throughout the parenchyma, and a longitudinal view, you can see the entire testicular parenchyma was involved. And this patient also has microlithiasis but developed a germ cell tumor. You can see the tumor centrally located inside the testicle. It's a hypoechoic mass. But you notice that the parenchyma around the testicle has microlithiasis. It has those bright echoes surrounding inside the parenchyma. Also notice the increased vascularity associated with the tumor. So if microlithiasis is encountered at an ultrasound, what do you recommend to the patient? Well, most often it's recommended that the patient do self-examination to assess for the development of the tumor. Because although tumors are 8 times more common in patients with microlithiasis than in those without, the risk of cancer is still quite low. A few have recommended annual physical exam or an annual ultrasound. And if a patient has a prior history of a testicular tumor, cryptorchidism, or subfertility, those patients should have closer surveillance than just self-examination. Now, sometimes we encounter other lesions in the testicle that are non-neoplastic. These could, for example, be granulomata from tuberculosis or sarcoidosis. Rarely, adrenal rest tumors will be found. Sometimes we'll see cysts. And then we also look for other complications such as torsion or infarction or inflammation affecting the testicle or infection, or we assess the testicle after trauma. Granulomatous orchitis can be caused by sarcoidosis or tuberculosis and may present either with focal hypoechoic lesions inside the testicle or may produce diffusely hypoechoic testicles with enlargement of the testicle itself. So here's a patient with sarcoidosis. This patient had multiple hypoechoic lesions in each testicle. On both sides, they were all similar in size and echo texture. And because of his history of sarcoidosis, the diagnosis of granulomata was made. Cysts in the testicle are uncommon but can be seen. They may be single or multiple, or they may be tubular, which is the result of a dilated reedy testis. Most cysts are located near the mediastinum. They do tend to occur in older patients, and most of the intratesticular cysts are non-palpable. That's as opposed to the tunicle cysts, which are on the surface of the testicle, which can be quite small but still palpable. So here's a patient with an intratesticular cyst. You can see it's an anechoic lesion with thin walls on longitudinal view, and here we see it on transverse view. Notice that it's right next to the mediastinum testis, which is the area of a slight increased echogenicity at the edge of the testicle, the site where the vessels and tubules enter and leave. This is the most common location for intratesticular cysts. This patient had dilated reedy testis. You can see this irregularly shaped clump of cystic areas. These are dilated tubules at the mediastinum of the testis. You can see it here and here. This is most commonly seen in older patients and very commonly associated with an epididymal head cyst, as we see here in this patient who has a very large epididymal head cyst. And this is thought to occur as a result of obstruction in the epididymis, leading to backup into the testicle with dilatation of the reedy testis. Now, the testicular parenchyma may suffer a vascular insult in one of two ways. It may undergo torsion, in which case the whole testicle is involved, or the patient may suffer a focal infarction. Testicular torsion occurs in those men who have a bell clapper deformity. That is, the bare area where the testicle is supposed to be anchored to the wall of the scrotum is narrow or small, allowing the testicle to swing on its stalk, obstructing its blood flow. The salvage rate after testicular torsion is related to the time since the beginning of the torsion. If the torsion is discovered and operated on in less than 6 hours, the salvageability of that testicle is excellent. From 6 to 24 hours, the salvageability declines, and after 24 hours, the salvageability of that testicle is quite poor. This is a patient who has a bell clapper deformity. You can see that there's a small hydrocele, that is fluid in the scrotum around the testicle, allowing us to see the entire bare area for this testicle. And you can see it's quite narrow. This is the only attachment of the testicle to the scrotal wall. So this could twist on itself, particularly in the presence of this hydrocele. With testicular torsion, we'll see absent blood flow in the testicle, and we may or may not see the twisted cord. So here's a patient who has acute testicular torsion. You can see that the right testicle is slightly hypoechoic compared to the left, and that with color Doppler, there's no flow inside this testicle. It's important when looking for blood flow inside.
And just so you guys know, the two-tone appearance is technical. That's nothing wrong with it. Well, this testicle does have something wrong with it, but it's not, that's just, the technologists didn't take the time to fix their TGCs.
The testicle to optimize the color scale for very slow flow, which we've done here, setting it at 2 to -2 centimeters per second. And still we can identify no flow in the right testicle, whereas we see good flow in the left. After 4 hours, the testicle becomes enlarged and edematous. It may have decreased echogenicity. The echogenicity may become heterogeneous. We'll still have no blood flow inside the testicle. We also may see thickening of the epididymis or the knot of the twisted cord with the epididymis, and a hydrocele may develop after 4 hours. So this patient has acute torsion. Here you can see the left testicle is smaller than the right testicle. You can see blood flow inside the left testicle and no blood flow whatsoever in the right. Also notice that the right testicle has homogeneous echo texture but is slightly darker than the left, and it's increased in size compared to the left. After 24 hours, we have what's called mistorsion. That is, the torsion has blocked the blood flow to the testicle for more than a day. On ultrasound, we'll still see no flow inside the testicle, but we may now see thickening of the scrotal wall and increased blood flow in the scrotal wall. The changes in the testicle will continue. It may be enlarged or edematous. There may be hypoechogenicity or heterogeneity. The epididymis will still be thickened, and a hydrocele is likely to be present. So here's a patient with a mistorsion. Notice the nice normal left testicle with a thin scrotal wall. Here is the right testicle. It's hypoechoic, heterogeneous, and there's marked thickening of the scrotal wall as well as increased blood flow in the scrotal wall, but no blood flow inside the testicle itself. Now, occasionally,
so I was going to tell you a story. I'll make it really quick. I actually had a patient like this. It was even worse. It was just like, you took one look at it, it was like, oh my God. And he felt nothing. I'm like, how is this possible? Well, 2 weeks prior, he had had a vasectomy, and the doctor snipped and then stapled. And when he stapled the artery as well. And so the testicle died. But he never felt anything because he was still under local anesthetic. And so his testicle basically, it's like a torsion, except it wasn't torsed. It was just stapled. But he never felt a thing because of the drugs, and so it was a bit of a shock for everyone involved that
Thickening of the
the testicle was gone.
scrotal wall, as well as increased blood flow in the scrotal wall, but no blood flow inside the testicle itself. Now, occasionally patients suffer a focal infarction. Nobody knows exactly how this occurs, but it does tend to be in older patients. And these patients present with acute pain. And what we'll see is either a wedge-shaped hypoechoic area at the periphery of the testicle, or we might just see a complex intratesticular mass. These masses are indistinguishable from tumors. So here's a patient who has an infarction. This patient did present with pain. We see a focal lesion at the periphery of the testicle. It's well defined. It looks like a mass. The only thing about this mass is it doesn't have any blood flow, whereas the testicular parenchyma does. This was still concerning for malignancy, and so they did remove it, and pathology showed a focal infarction of this part of the testicle. This patient presented with pain and had peripheral lesions, as we see here and here. You can see them again on this view, and you can see there's no blood flow to them. The diagnosis at this time was thought to represent an infarction, so these lesions were followed. And indeed, 6 months later, you can see that they're much smaller. So these are resolving peripheral infarctions that had occurred 6 months prior. We still see a residual hypoechoic lesion. It does extend to the periphery. In one view, it is wedge-shaped. Scrotal infection can involve the epididymis. It can involve the epididymis and the testicle, or it can involve just the testicle. And we can see changes depending on what kind of infection it is on ultrasound. With epididymitis, there's thickening of the epididymis with increased blood flow to the epididymis. There may be a hydrocele, and there may also be an associated thickened spermatic cord. So here we have a patient with epididymitis. You can see that the epididymis sits above the superior pole of the testicle, and in this case has a lot of blood flow. You'll recall I mentioned at the beginning that we typically do not see much blood flow in the epididymis in a normal patient. But when the epididymis becomes inflamed with epididymitis, the blood flow does increase. On this clip through the scrotum, we can see thickening of the epididymis here as well as a hydrocele. Now this patient went on to develop an abscess, which we see here. You can see that there's now a cystic complex fluid collection sitting adjacent to the testicle here and here. This is an epididymal abscess that developed from the epididymitis. This does not happen too often, but it can happen, and ultrasound is a good way to monitor these patients. Here's a patient with acute epididymitis involving the tail of the epididymis more than the head. We see on this longitudinal view of the tail, this was bilateral, we see the longitudinal view of the left tail shows marked thickening and hypoechogenicity. Here it is on transverse, and here is the marked increased echogenicity. In addition, the right was involved as well with the tail, so this is a longitudinal view of the right testicle showing thickening of the epididymal tail. Some infections start in the epididymis and affect the testicle as well, becoming epididymo-orchitis. In these cases, you have all the findings of epididymitis, but you also have abnormalities inside the testicle. You will see a hypoechoic area in the testicle, typically at the periphery, typically in the region of the involved portion of the epididymis. There will be increased blood flow to the testicle as well as the epididymis, and the spermatic cord will be thickened. So here's a patient with epididymo-orchitis. You can see that there's marked thickening of the epididymis. You can also see altered echogenicity in the right testicle on the clip, as well as here on transverse view compared to the left, and marked increased blood flow inside the right testicle. Infections isolated to the testicle are called orchitis, and these are often different organisms. This can occur from tuberculosis, from mumps, or from retrograde travel of the infection from the lower urinary tract. When orchitis is present, the testicle will be increased in size with increased blood flow, and the echogenicity will be decreased either diffusely or in a heterogeneous manner. So here's a patient with orchitis. We can see when we look at the side-by-side view of the left and the right testicle that the right testicle is mildly enlarged. The echogenicity is pretty homogeneous, but it's not quite as smooth as the left. But when we put the color flow on, we can see how there's marked increased blood flow inside the involved testicle as compared to the normal left side. Look at all those vessels traveling across the inflamed testicle. Because of the scrotum's location, it is at risk for direct trauma. After trauma, a hematoma may be found in the scrotum. It may be in the epididymis. It may be in the scrotal wall. It may form a hematocele. In addition, the testicle may be damaged with a contusion or a rupture. So here's a patient who had an acute hematoma. The scrotum was markedly enlarged after trauma, and we saw this large collection in the upper portion of the scrotum. And here you can see that it's a fluid collection that moves with the ultrasound beam. The testicle was compressed inferiorly by this very large hematoma. This patient has a hematoma that is resolving, so it's been here for a little while. We can see that it has the typical web-shaped crisscrossing septations across it. This is a typical appearance of a resolving hematoma. Again, this is compressing the testicle inferiorly in this case. Sometimes, though, the testicle's involved, so we need to look at the testicle carefully after trauma. With a contusion, we'll have hypoechoic or anechoic lesions that will have poorly defined margins. With a fracture, you get a hypoechoic band right across the testicle, and with rupture, there's disruption of the capsule of the testicle. Here's a diagram of what happens with testicular rupture. You can see there's a tear in the tunica albuginea, and some of the parenchyma is extruded through the gap in the tunica albuginea. It's pretty common also to have a hematoma associated with this. So here's a patient with testicular rupture. You can see this patient also has microlithiasis. This is the normal left testicle, and this is the right testicle. And just on this still image, we can see that the contour of the posterior wall of the testicle is bulging and distorted because of disruption of the capsule. When we look longitudinally, we see disruption of the posterior lower pole of the testicle with protrusion of some of the testicular parenchyma. And then if we look at the clip, we can see that region of extruded parenchyma through the defect in the tunica. This patient has a testicular contusion. Contusions can look like intratesticular masses and can raise concern for malignancy. Here we have the well-defined lesion that's hypoechoic and heterogeneous. And so because of the fact that it can be confused, this may sometimes come to resection. Also, remember I said at the beginning that 10% of testicular tumors, cancers, present with a history of trauma. So if this patient comes in and has this ultrasound where there's this focal hypoechoic lesion, we do need to raise concern that this could be a tumor. If whoever is treating the patient wants to wait a little bit and see if maybe it is a contusion, close follow-up is recommended. Fortunately, with contusions, they do get better quite quickly. They get smaller in size rapidly. And sure enough, here's this patient who was followed monthly, but for 9 months. And you can see by 9 months now that contusion is almost invisible now.
You ready?
Yeah, I'm ready. Oh my God, is it back?
Oh my.
I don't even know him. Hey, man.
Now on ultrasound have
Sorry, I was getting into that.
been collapsed down and resolved. Besides the testicle, we look at other things in the scrotum, including the epididymis as well as the scrotal sac. So we look for fluid from a hydrocele or a varicocele or even a hernia. Epididymal cysts are spermatoceles that are typically located in the epididymal head, but they can be anywhere. They are focal dilation of the tubules that contain the sperm that they're carrying from the testicle and then into the spermatic cord. They're usually asymptomatic, but they may be palpable in some situations. So this patient has an epididymal head cyst. Here you can see the testicle is normal, but above it we see a well-defined cyst here and here located in the epididymal head. And as I said, they're typically anechoic with thin, smooth walls. Now, hydrocele occurs because fluid collects between the visceral and parietal layers of the tunica vaginalis. These can be congenital, but often they're acquired either from inflammation or a tumor or a trauma, or they could be idiopathic. So here's a patient who has bilateral hydroceles. You can see that we have very large scrotum with lots of fluid around both of the testicles. The testicles are normal, as we see here, with normal blood flow. Here again, we see one of the testicles here with a lot of fluid inside. And if you look carefully in patients with hydroceles, you can actually see the appendix testis sticking off of the testicle. This is a good view, again, to show that bare area. This patient has a normal bare area with the testicle attached to the scrotal wall in this wide area. So this is not a bell clapper deformity, but a normal attachment. Varicoceles are dilated veins of the pampiniform plexus. Sometimes they extend into the testicle. They're more common on the left than the right, but are bilateral in 25% of the cases. They may develop from a retroperitoneal neoplasm, which obstructs the venous return from the scrotum. The pampiniform plexus is the plexus of veins around the spermatic cord extending down into the scrotum. You'll notice that these veins drain into the testicular vein, and on the left side, the testicular vein drains into the left renal vein, whereas on the right side, the testicular vein drains into the inferior.
Do you think that video games are going to be here to stay, or are they just a fad that's going to go away?
It's over here to stay.
Vena cava. This is why, if there's a retroperitoneal tumor, you may have a varicocele, because that tumor may compress the testicular vein, leading to backup of blood inside the scrotum, causing a varicocele. The ultrasound findings in a varicocele are serpiginous tubular vessels in the scrotal wall. The diameter of these vessels is 2 millimeters or more, and we may see slow flow either with the grayscale or with color Doppler. So here's a patient with a varicocele. You can see that there are tubular vessels in the scrotal wall. Here, this one is measured or pointed to with an arrow. On the two-dimensional image, you can see flow inside these veins. It's very slow flow, so that you can just see it with the real time. And here we see flow that's been elicited by a Valsalva maneuver inside with color Doppler. And here's another one. We can see that there are lots of serpiginous vessels, but on the color flow, we don't really see that this is flowing because it's so slow that the color cannot pick up the flow. But if we just look at the grayscale, we can see these tons of serpiginous vessels with lots of venous flow inside them.
Oh. Well, that was kind of a quick end to that video, which 252. What the hell? I'm ready to go. No homework today, no homework tomorrow. I'm getting into chapters that are taking more of my time, and I'm just not able to get to it. So. All right, I'll see you tomorrow. Unless anyone has any questions or anything. No?
I do, Mr. S, real quick.
Sure.
When were you going to be posting the new schedules?
Oh, I'll do that right now. In fact, let me get the. All right. Whoops. I can't see you guys. All right, I got Blackboard up. I will post them and send them in 5 minutes.
Okay, thank you.
All right. Thanks for reminding me.
You're welcome.
All right, guys. We'll see ya.